Hi, folks. Let's really jump into this episode number 9, the final episode for the Rising Stars season 3, where we are actually going to talk a little bit specifically about the art of refractive surgery. And I think our speaker today is going to wrap up all the seasons, all the episodes in one really, really interesting episode. But let me explain a little bit about how this whole thing works. It's basically we one Rising Stars and we surround them with celebrity panelists. These celebs are the ones we've always cherished and loved and see them in big meetings. But unfortunately, they have a very, very busy schedule and they're we're thankful to having them in our session over here. This is a very interactive discussion. So any audience member, wants to throw in a question, we have a YouTube channel, you can pop in and throw in a question there. Bill and I, as moderators, will put forth these questions to the panelists and the speaker. We're live on risingstars.com and on YouTube channel called Rising Stars in Ophthalmology. The reruns obviously can be watched, as it's a very global event, can be watched on our website. Also watch out for our social media feed on Facebook, Twitter, LinkedIn, and Instagram, where we'll be releasing small educational tips and snippets from all the episodes. I'd really like to thank every one of you for tuning in, and thank you sponsors for making this happen. And now I want to hand over to Bill to kind of introduce the speakers and the panelists. Bill, over to you. Bill, you're on mute.
Sorry about that. I apologize for that. I was so excited to put together or share the presentation, so I jumped into that. Okay, so hopefully now you can see. We'll see if we can share my screen, and thank you for that little. Yeah, this is my first time, I guess, using Zoom. Okay, so anyway, here we are. Again, I'm super excited to have Arjan present today. We have an amazing celebrity panel. So I'm going to just run through this kind of the introduction, sharing a little bit about each of our celebrity panels and why they're so valuable to tonight's presentation. So first is Robert Maloney. I have so much fun working with Robert. Here's his bio. He went to Harvard College and then University of California. Sorry, slide this over here. Then he went to Johns Hopkins University for residency. Then his fellowship in corneal refractive surgery at Emory University. And of course, he's currently his position. He's at the Maloney Vision Institute, and he's chairman of the board of directors for ACOS. And then my favorite fun fact about Robert is we get a lot of chance to ski together, and he is the ski champion right now for the ACOS ski race that we have every year. So right now, he is the #1 skier. So I don't know, Robert, any comments on skiing? And I know you're a big fan of Lindsey Vonn, so that's why I have her up here.
Bill, I was lucky to beat you last year, and I'm just hoping I can do it again, but I'm not putting big money on it. Everyone should know that you were on the Dartmouth ski team in college, and so I always feel you snapping at my heels when the rare occasions I'm in front of you.
We have a lot of fun on the ski slope. So, thank you so much. And again, Robert's just been he's been the leader in the ski race the last couple seasons. So, with that, we'll jump into Greg. Greg, we're lucky to have Greg Parkhurst, who's did his college at Hillsdale College, and then went to medical school at Northwestern University. Did his residency at Walter Reed Army Medical Center, and then did his corneal refractive surgery fellowship with Stephen Slade and Dr. Baker at the Slade and Baker Vision Center. And his current position, he's at the Parkhurst New Vision Center, which he's the founder of, and he's also past president of the Refractive Surgery Alliance. And Greg was kind enough to share his fun fact, and I'd love for you to elaborate a little bit on this. Your fun fact is you love fun Halloween costumes. Let's just share a little bit more about your fun Halloween costumes.
Yeah, it's definitely my wife's and my favorite thing to do is to dress up like a couple's costume every year. And our favorite one was when we went as figure skaters, and I had the whole like unitard and this little peacock feather off of my finger, and she had this really cute thing as well with the whole leotards and everything. So yeah, that was our best Halloween costume.
Okay, and where's the photo? We should have been showing the photo of that.
Yeah.
So next time we'll have to share that photo. Awesome. Well, thank you so much for being here as well. And then, of course, we have Sonia Yu as a celebrity panelist. I'm lucky enough to be in the same city as Sonia. She's just an amazing individual. I see so many of her patients who see her and just rave about her all the time. She went to college at Stanford University and then medical school at Case Western Reserve School of Medicine. She did a residency at Mass Eye and Ear, her fellowship as well at Mass Eye and Ear. And she's currently the Greentree Pruitt Hickman Chair in Ophthalmology at Bascom Palmer Eye Institute. And she's also the executive board of the International Society of Refractive Surgery. And I think so. Everyone has fun facts, but Sonia, you probably had the most fun fact of all of us. So here's Sonia's. Sonia, why don't you share a little bit more about what your plans are for this coming week?
Yeah, I'm headed to India, as I shared with the rest of the group here. And I'm planning to do elephant cataract surgery on some aging elephants. So I'm going to get my life insurance up to date, and hopefully all will go well.
I know it will. That's amazing. We can't wait to see the videos from your surgery. Super exciting. And perfect. And then lastly, we have, of course, our star tonight, our rising star, Arjan Hura, who's just amazing. I've had a chance to know Arjan for a few years. We would have loved to have had him at our center in Miami, but he decided to go to the West Coast and join an amazing practice on the West Coast. Arjan went to Ohio State University and then University of Cincinnati for medical school, stayed for his residency at University of Cincinnati, did his fellowship with Bill Wiley and Shamrock Bafna at Cleveland Eye Clinic, Clear Choice Custom LASIK Center. He's currently with Robert Maloney at Maloney Chamonix Vision Institute. And Arjan's fun fact is, why don't you share a little bit more about your fun fact of loving martial arts?
Yeah, a lot of people grow up when they're kids, they play football, soccer, track and field, wrestling, tennis, any number of sports. I grew up and I was practicing martial arts, Shotokan karate, 3-4 nights a week and on Saturday mornings. And Bill, I was going to save this fun fact for the one to watch feature that I'm putting together that's coming out in a couple months, but I've never really said this publicly before, but I'll say it tonight in the spirit of having something fun. But actually, when I was a resident, an ophthalmology resident, I was concurrently working on pursuing an Olympic bid for the Tokyo 2020 Olympics, because that was the first time in history that karate actually made it into the Olympics. There was a change to the qualification process, and then obviously the COVID-19 pandemic hit, so that kind of prematurely ended. But it was a fun 4 to 5 years training for that.
Oh my gosh! Wow. Sorry. I'm sure there's some other fun events. We can't wait to see you in action. And again, maybe next time we'll get a video of you in one of your competitions. Okay. So thank you. Also, I asked Arjan was kind enough to share just a little collage of photos. So why don't you just run through some of these fun photos from your training, from all different situations. So Arjan?
Sure. Initially when I was putting this collage together, there was all these photos of me as like a kid and my family. And then I said, you probably don't want to hear about that. So why don't I focus on people that everyone here knows and loves? So from the top, that was a photo of me at my first Millennial Eye live meeting in 2019 in Louisville, Kentucky. And that's actually where I met so many of the people on this slide who have become my close friends over the years. And we have so much fun getting together at meetings and catching up. The next photo was a bunch of people who are in California or close to California. Top of the center there, that's obviously Bill Wiley. He was my fellowship director. That's a photo of us at the most recent Acosteer Valley meeting. And of course, that's myself and Netta Shami. And this was actually before I decided I was going to come to LA. After I had already interviewed at the practice, we were kind of touching base and catching up and discussing the future. So that photo was taken after a very pivotal conversation. And then all the way top right, that was when we were recently in New Orleans, I believe, for Academy. And so that was a fun night out with a bunch of people, and everyone was enjoying the New Orleans night. In the middle there, that's Brett Mueller, a very good friend of mine. Pam Katz, who is an amazing photographer and probably took half the photos on this slide. Brian Schaefer and I were recently at the Telling It Like It Is meeting, and after we both presented, we decided to step away for a bit and just caught up and hung out in the pool for 4 to 5 hours in the nice Florida sun. So that's always a blast. And then Jim Katz in the middle there, that was also at ACOS Deer Valley. George Waring in the center, who's been a dear friend and mentor of mine. And I've recently had the pleasure of co-instructing the ISRS LASIK skills course with him past couple of years. The middle photo is a bunch of friends at one of our first ad boards together a few years ago. Middle right there is some of the fellows and Bill Wiley and Shamik Bafna. That was at ASCRS 2020 in Vegas after the tail end of the pandemic. Then some of the BMC team there, we got Rana, Bree, Tammy, Natashami, and myself. A bunch of the close friends. Christos is actually not in that photo. That's a floating head. I photoshopped him so he wouldn't feel like he was missing out. And then just a bunch of other photos from across the years. And then, of course, when I interviewed with both Robert and Ned out here in Los Angeles, that's a photo we took of that one of the evenings.
Amazing. Awesome. Well, I'm going to end my share here and turn the screen back over to you, Arjan, so you can share your screen and share your presentation.
Can everyone see that okay? Okay, wonderful. Well, hello to everyone from around the world. I'm so excited to...
I think you're on the presenter view, that's all. I think.
Oh, okay, let's do this. Let's redo that.
Might need to swap a display or something.
Yeah. Is that better?
No, it's not changed. I mean,
I think, Rajan, you need to choose the other display to share, not this one.
Let's see. How about that? Finally?
perfect.
All
Good.
right, geez. Not my first Zoom time either, huh? Maybe my first time from a dual monitor setup. Well, like I said, it's a pleasure to be here with all of you. A good evening from Los Angeles. And I know, Ashvin, it's just the crack of dawn where you are. So we really appreciate everyone being here tonight. I really do feel honored to close out this third season, to do the finale for Rising Eye Stars in Ophthalmology. It's interesting, when I first knew I was going to be the closing episode almost a year ago now, I had this idea for this topic of the art of refractive surgery and navigating and walking the tightrope between scenarios that are black and white and the gray area in refractive surgery where there's not necessarily a right answer. And then over the past several months, I've literally seen every presentation go by and I was like, oh, I was going to talk about that. I was going to talk about that. And so a few weeks ago, I was like, well, what am I going to talk about now? How do I tie all of this together? So I think it's going to be a fun night, a fun evening of good discussion. I do want to pay homage to everyone who's come before here. A little mini retrospective. The season kicked off with Brian Schaefer talking to us about transforming the patient experience in anterior segment surgery. Deborah then took us a little bit of a deeper dive into refractive cataract and MIGS surgery. Morgan helped us navigate through cornea and cataract challenges. Nicole talked about new and exciting technologies in cataract surgery. Eric really touched on something that's probably going to become more and more prominent over the years, which is the effect of AI and digital ophthalmology. And hats off to Eric for his efforts on getting a digital day at ASCRS. Joaquin told us about the mindset, having a refractive mindset, how to just think about having a terrific outcome from a refractive standpoint, regardless of whether it's cornea or cataract surgery. And then Una shared a lot of personal pearls and pitfalls from introducing new technologies in solo practice. And then finally, Sela took us globally and then really shared the impact of ophthalmology and ophthalmology at large in humanitarian efforts. So I'm happy to have learned so much from all of these amazing presenters. And of course, I do have to thank all of our visionary organizers here, Drs. Ashwin Agarwal, Jen Lowe, Bill Tratler. A big thank you guys. Big thank you to you guys for the highlight and also for just creating this platform. It's been really wonderful to learn from everyone over the years. And then, of course, our expert celebrity panelists, Drs. Robert Maloney, Sonia Yu, and Greg Parkhurst. Robert, I have the pleasure with working side by side with every day, so it's really a lot of fun. Sonia, I've learned so much from you over the past several years, and it was such a pleasure about a year ago co-hosting How to Get Started in Research symposium with you. And then Greg, just a brilliant refractive and cataract surgeon. I had the honor of visiting his practice when I was interviewing for fellowship, and there were just so many amazing little pearls I took away from my observations that I still kind of think about on a week-to-week basis and have implemented in my own practice. So it's a pleasure to be here with all of you tonight. And maybe, we've talked a little bit about skiing and elephants, but maybe we can try and get to know each other a little bit better. So Sonia, I'll start with you. You are a professor of ophthalmology. You are in the mecca of academic ophthalmology at the Bascom Palmer Eye Institute, consistently ranked #1 year after year. Could you maybe share a little bit about your success and what is it about what you do in clinic or the operating room for patients that has led to this reputation of you providing such great patient care? Any pearls about really optimizing the patient experience?
Well, I think one of the great things that Bascom Palmer has is it just has a huge volume of patients with all kinds of pathology. So really, that's the luxury that we have is that we see patients with all kinds of levels of eye disease, and we're also in a tropical climate, so we have the opportunity to see unusual eye diseases, maybe that Ashvin sees, but ones that aren't so common in the rest of the United States. I've been really fortunate to work with some great colleagues, and I think that's one of the other nice things that's special about Bascom Palmer is that because we're a large institute that's highly subspecialized, we have access to, picking the brains of our colleagues that are down the hall or upstairs. And I think Guillermo Amezcua and Carol Karp I saw were prior panelists on prior series in Rising Stars. And it's great to be able to practice with such colleagues that I love to work with and who I admire.
I couldn't agree more. It's always a blast when you get to work with friends, and I'm fortunate I get to do that every day. So Robert, you and I, we are arguably in maybe the most saturated part of the country for cataract and refractive surgeons, maybe jockeying with New York a little bit for that title. There's so many ophthalmologists in LA. What is it you feel that makes us unique? Why do patients choose us? You're on.
Arjan, our secret is we recruit rising stars out of great fellowships and then have them come teach us the newest things so we can always stay at the edge of the learning curve. So we thank you for that.
I appreciate that. I will take it. And
Greg, I was going to say that what we try and do, a lot of doctors pay a lot of attention to their medical care, their surgical techniques, the diagnostic techniques, the instruments they use, and that's really important. We also pay a lot of attention to the patient experience, and in a very competitive place, that helps.
Yeah, totally. Well, Greg, I know you're probably not quite as familiar with LA being in San Antonio, Texas, but in LA, if you drive 2 to 3 hours, you're still in LA, and you've maybe gone 10 miles, but that's not really the case where you are. In Texas, you got Dallas, Fort Worth, you have Austin, you have a lot of ophthalmologists who are close to you. And like I said, I really do remember fondly that visit to your practice. These are just some photos. You have such a gorgeous practice. I mean, it's really this luxury experience for patients. Can you tell us a little bit about how much intention you put towards maybe the aesthetics of the patient experience when you were putting your practice together, and maybe one thing that makes the patient experience unique at your practice from the moment patients walk in?
Yeah, well, we really focus on refractive surgery. That's our mission, is to kind of cure myopia one diopter, at a time and rid the world of that terrible disease, myopia. So since our focus is refractive surgery, we're constantly making a new first impression for all of our patients that come in our doors. We don't typically see patients back for annual eye exams. We don't focus on glaucoma maintenance. We're really focused on correcting refractive errors, so that patients can just kind of enjoy their life and live without that extra inconvenience on their face. And so we try to design a facility where we can treat people like they're important guests. And oftentimes patients come into our facility and they're like, hey, it kind of feels like I just came into a hotel. And we did have some intentionality around building it that way. So our whole culture is around service and making our patients feel like they're the only person in the room and giving them, the utmost attention that an important guest should receive.
That's fantastic. And that is a perfect segue. And really what I want to focus on tonight, which is the service aspect, patient experience, really the art of practicing medicine or the art of practicing refractive surgery. We're fortunate enough with modern diagnostic technology, surgical techniques that, 98, 99% of the time, things go really, really well in refractive surgery. But it's that 1% of cases when maybe things aren't perfect or the way you like, that's really when we need to rise to the occasion. And so rather than go over surgical footage or techniques or peer-reviewed literature, I've selected a bunch of cases that I think will be really fun to discuss where there's no tricks, there's nothing hard, there's no right or wrong answer. And I think it'll just be very interesting to hear everyone's different perspectives and techniques. And so we're going to delve truly into the art of refractive surgery. So this first case, 30-year-old male, very high myope, as you can see. He has a history of a retinal detachment in his left eye, had a sclerobuckle, and he comes in and laser retinopexy, and he comes in wanting vision correction. But due to his occupation, he works as a mechanic. He's constantly working underneath cars. He's really worried about getting chemicals or debris in his eyes, and he just doesn't want LASIK. And so that's his refraction there. You can see his very thick corneas, normal topography, normal tomography. I'll pose a question to you first, Robert. Just normal eye exam here. How would you proceed?
I normally don't do LASIK above about 8 diopters of myopia, except in unusual cases. So clearly LASIK is not the right thing in my mind for him. You could consider refractive lens exchange. I am not a big fan of refractive lens exchange in high myopes because we know the risk of retinal detachment is substantially higher. And you could argue that his retina has been stabilized because he's got a scleral buckle, so the risk of retinal detachment is probably lower in him, but you'd end up doing the same thing in his right eye. And there he'd have a higher risk because he's already had a detachment in the other eye. Finally, you take away his accommodation. So this is an easy case for me to do an ICL. The only thing that would give me pause is if he'd had a vitrectomy, because that can cause zonular compromise, but it's even then probably not. A vitrectomy, though, would mean he'd be likely to get a cataract, and that would be the one thing that would steer me towards RLE in him. Sounds like he didn't have a vitrectomy. So I'm thinking ICL in him, likely an emmetropic correction in both eyes because he can still accommodate.
Yeah, and he did not have a vitrectomy. He has very deep ACs, so he's a great ICL candidate. You touched on something where you said you don't really like to do LASIK on patients who are more than a -8. And so I'll turn the question to Sonia and to Greg. Do you guys feel the same way? Do you guys have your own sort of personal thresholds for when to do LASIK on high myopes?
Yeah, I'm the same. I don't tend to do LASIK in patients over -8, -9. I just feel that it has a tendency to affect the quality of vision. And we have good options like the ICL and now the toric ICL to help us with these higher myopes.
Yeah. So Greg, let's say, you talk to this patient, you recommend ICLs, and the patient, for whatever reason, let's say they're just very nervous about intraocular surgery or they can't afford the surgery, but everything else, they look great in terms of LASIK, and you've explained the side effects, everything Sonia just mentioned and Robert mentioned. Is this someone with good informed consent or modified informed consent, you would feel comfortable doing LASIK if they didn't want to have ICL surgery?
Not both eyes of this patient. I would consider the right eye under that scenario, but not the left with that amount of myopia. So I would inform the patient that toric ICL is my recommendation, and if they can't afford it right now, it'd be better for them to save up for a year or two and come back and do it in the future rather than having the wrong procedure.
Yeah, I totally agree. And the beauty of being able to practice the whole spectrum of refractive surgery, apart from just doing LASIK, is, if you only have one option, and you have a hammer, everything looks like a nail, but there is an art to tailoring the right procedure to every patient's eyes. And sometimes that might mean no procedure at all. And sometimes that might mean waiting a little bit to have the right procedure when the patient can move forward with that. So thankfully that wasn't an issue with this patient. So he was fine with ICL. So he proceeded with toric ICLs in both eyes. Just, he was thrilled. He was ecstatic with his post-operative day one results. 1 week later, he comes in and the ICLs have rotated almost 90 degrees. And so, Robert, I'll pose the question back to you. How would you proceed now?
Let me take one step back, which is I just like to underline what Greg said, which is he told him to go away and come back when he can afford it. One of the things that's hard for a lot of refractive surgeons to do is say no. And it is the most important word in your vocabulary. I learned that the hard way several times. I learned it very painfully. And so if the audience takes something away from this, that would be the thing I'd want them to take away, which is if you're not comfortable, say no. And if they don't like it, that's too bad. So come to this. ICLs do rotate, particularly toric lenses. Don't know why. Very frustrating. Rare, but frustrating. There's two ways to approach it. If there's a low vault, I exchange it for a larger ICL at the correct axis. And if there's a high vault, you don't want to do a larger ICL. And then there's another way to approach it, Arjan, which I think you're presenting at ACOS. So I'll let you tell us about that. What I have not found effective is rotating them back to the correct axis without exchanging the lens. My experience is they just rotate back. So the one thing I wouldn't do is just go in and rotate.
Yeah, and so this was a patient where the vault actually looked pretty good, but what was interesting was the whole ICL was relatively decentered. So, you can sometimes, especially EVO ICLs, you look at the central port, and sometimes it's close to the visual axis. It might be a little bit off. This was dramatically displaced inferiorly, but, there's no pressure issues. And so, again, the question was, do we size up? Is this too small of a toric ICL? And it was a 13.2, so I'll ask Sonia and I'll ask Greg. Do you guys put in a lot of 13.7s? Maybe
No,
Greg, starting with you. Yeah.
No, rarely. A couple times a year we use a 13.7. And usually if it's twice a year, one of those two times is a scenario like this where I started with a 13.2 and I have to go up. So it's almost never my primary lens. I do have a couple of these where clearly, I think what's going on here, you've got it. The lens is too small. And so the amount of cylinder that you can refract can be really confusing because you're not refracting the center of the optic of this lens anymore. So you're like, is it rotated? Is it just off axis? Is it some combination of both? But I think clearly this lens is too small. I've had a couple of these where I used a 13.2 just like this, and I exchanged for a 13.7, and it's still too small. There are eyes out there that even a 13.7 doesn't fit well, and we've had to explant the 13.7 lens. So there are some. Maybe it was Sonia's elephant eye that I was dealing with. I'm not sure, but they're out there.
Yeah, definitely feel the same way. 13.7 is such a rare ICL to go in, and so we're looking at this, and we reviewed all the biometry, reviewed everything. There was multiple ICL sizing formulas that were used, and everything was in agreement for a 13.2. So the thought was, well, pretty rare that it would rotate in both eyes due to just retained viscoelastic, but let's give it another shot. And so we proceeded with toric ICL rotation in both eyes again. Again, terrific result day one. Really took a lot of extra care time to really make sure that everything got irrigated out. And then sure enough, week one, they've rotated almost 90 degrees again. And so we're back to the same position. And so I'll ask Dr. Maloney, Dr. Robert here, what would you do in this situation? You've taken the patient to the OR twice now, and we're all the way back to square one.
It's so hard to tell them you got to go back a third time, but obviously you do. I'm very concerned by the decentration. That can be a sign of a zonulopathy. I've seen one case where an ICL ended up in the anterior chamber, in the posterior chamber through a zonular defect. I think that's probably unlikely here because I don't think it would be bilateral. And so I would switch to a 13.7, put them at the correct axis, and cross my fingers.
Yeah, that's exactly what we were thinking. It probably not a zonulopathy, and there was no really like the vault was fairly consistent throughout. But after this having happened twice, the thought was this is definitely too small of an ICL. The patient probably needs a 13.7. But then the question is, well, let's say you explant the 13.2, you put a 13.7 in, and what if that's too large, or what if that rotates again? And now you're looking at maybe a fourth or even a fifth surgery. When you're in these situations, when do you just call it quits or come up with an alternative solution? So anyone have any thoughts on that?
I mean, one of the other challenges that goes along with that too is that oftentimes if you need to order a toric and a 13.7, you're going to have to wait 6 or 8 weeks for them to manufacture that specific lens. They typically don't inventory these 13.7s and all these powers. And so you're kind of also left with this time issue to deal with. You know, what are you going to do for the next 6 weeks while we're waiting for the lens to be made? So it can be a tricky decision. I think one of the things that I do is I try to decide, you know, how small does this look in the eye? We often, you know, you can kind of tell by the slit lamp, but we also sometimes we'll use a UVM to try to get a sense for, you know, do we think a 13.7 is going to be able to be stable in the sulcus, or is it going to be too small too? And in those cases where either we're concerned possibly it could be too small even with the 13.7, and or we've got to wait a long time, we'll sometimes make the decision to put in a spherical lens and then do a bioptics approach on the cornea to touch up the astigmatism. So that's just one other option that you can sometimes consider.
Yeah, and so Greg, exactly that situation. We have a scenario where that ICL is rotated twice. We could put in a 13.7, but the patient's running out of vacation time, taking time off work, needs, you know, lives kind of far away, needs a driver to bring him in every time. There are all these other aspects of things beyond just the surgery that we're having to deal with. And so we ultimately decided what is the safest bet here that will minimize the amount of surgeries that this patient will need or could end up needing to get them to a good result. And so we proceeded with toric ICL implantation. We put in spherical ICLs, intentionally undercorrected the patient to leave the patient with residual myopia because we knew we couldn't do LASIK for this patient. He didn't want LASIK. PRK, he just couldn't take that much time off work to recover from. And that left SMILE, and he's a terrific SMILE candidate. But SMILE, you have to have at least 1 diopter of myopia to even treat any refraction. And so we had to leave him a little undercorrected. So that was his residual refractive error. And then the plan was to proceed with SMILE. And so, Sonia, I'll ask you, how do you, because so much of whether the patient's going to accompany you through this journey is your bedside manner, the confidence they sense in you, you know, your charisma, your warmth, that you make them feel comfortable and cared about. How do you talk to this patient? How do you navigate 3 or 4 different trips for an elective cash-based procedure to the operating room?
Well, I think it's tricky, like you talked about, but, you know, I think that frequent communication with the patient and conveying that you're going to see them through the process is very important. And also to reassure them that, you know, in advance that there may be some enhancements that are necessary to get them to the final goal. If you communicate that at the beginning, then usually there's less anxiety on the patient's part when there is an additional procedure that needs to be done. I think in some ways, you know, now that you're going to a laser procedure rather than going back to the OR, might be a little bit less scary for the patient. But it can be tricky, and now we're going into the 3rd procedure for this patient. So I think the communication, open and frequent communication is very important.
Yeah, and I think you nailed it on the head. And that was why the patient was comfortable going forward with a 3rd surgery to explant and exchange the ICLs, and then a 4th surgery down the road to have SMILE. And so that's ultimately what we ended up doing. We implanted the ICLs. We did smile after that, and then the patient was just thrilled. And we touched on this a little bit, but Greg, let me ask you, if you do enough surgery, especially do enough refractive surgeries, you're getting sent these patients who have really high refractive errors, maybe odd angles, sulcus anatomy. When you have a patient that's been with you on such a long journey and you finally get them over to the finish line, do your practice, do you do anything special for that patient to celebrate their vision, to sort of, thank them for sticking with you on the journey and getting to this spot?
I've found that patients that have an atypical course like this, where you needed to do a couple of different interventions, and it's not what they expect. It's not what anyone expected, that it was going to require these additional surgeries. This is, like Sonia said, this is the most important time to deepen that doctor-patient relationship. Lean into more communication. Do extra things. I can recall a patient several years ago that we took care of out of state. This was an ICL patient as well. And this was pre-Evo, but when she flew back home out of state, she actually went into a pupil block and had, out of state crisis of an angle closure episode. We were able to talk with her on the phone, and they got on a plane quickly and got back down to us, but they had to leave for the airport so quickly that they didn't have time to even pack their bags. And the mom just brought the patient, and we went, straight to the OR to explant the ICL. But the mom and the daughter came from out of state with no bags and no clothes. And so we picked them up from the airport. My wife went to the store, got them pajamas, took them to the hotel, gave them, pajamas to wear. And this is a patient that is now, tied to us all these years. It's a patient that I remember, and we have a great relationship. She's come back a couple times over the years. She had to come back actually recently for Evo, matter of fact, in the other eye, because we decided that without the Evo lens, putting a different size ICL wasn't going to be stable. So all these years later, she came back and ultimately had an Evo put back in. But it's because of that extra effort. You wouldn't think of having your spouse go and pick up pajamas to take, to the patient and the mom while they're in the hotel. So yeah, it's important to do anything you can to demonstrate how much you care, to get patients through unexpected outcomes like that.
Yeah, that's a really great story, Greg. And so for this patient, we ended up sending him on a really nice dinner for him and his wife, just as a thank you for sticking with us through the journey. But your story reminds me of a case we had a full day of surgeries lined up, refractive surgeries. A lot of them were smile, and there was an issue with the laser where it went down for the day, and it wasn't going to be able to be serviced that day. It wasn't going to be functioning until the next day. And we had a satellite about an hour and a half away. And so we offered patients, we kind of rented a black van and offered the patients to drive them up to the other satellite to use the laser there to still do their smile surgery on the same day. And I think even though no one accepted that because they were all fine with just doing LASIK, everyone really appreciated that, extra mile, that extra gesture. And I think that's all stuff, we're not taught in medical school. We're not taught in residency, the art of dealing with patients and this sort of stuff. So this next case here, this is a 55-year-old male, history of hyperopic LASIK and monovision, about 15 years ago. And again, he comes in, he wants vision correction. His topographies look terrific, well-centered ablations. Everything else is otherwise normal. And so I'll start again with you, Robert. How would you proceed with this patient? Would you talk to him about doing maybe another laser vision correction procedure, refractive lens exchange, do nothing?
Why do they need surgery? Have they drifted hyperopic?
Yeah, drifted hyperopic again.
I don't like doing more than about +3 diopters of hyperopic correction in total. So if he was a +2 ahead of time and now he's a +1, that would be my limit. I also am not a huge fan of hyperopic PRK, which is what you'd have to do in this patient. Also, to recreate monovision, you're probably looking, just guessing, an ablation of 2 to 3 diopters. So this patient screams for refractive lens exchange, and that would be my go-to procedure in general for a patient who's had hyperopic LASIK, now has a hyperopic drift, and is in the presbyopic age range.
Sonia, I'll turn the question to you. Let's say this stem aside, let's say you have a patient has had LASIK in the past, and it's been 6-7 years now, and they need an enhancement. Do you also, like Robert, typically opt for PRK? Are there any situations where you feel comfortable lifting a flap? Because there's a lot of our colleagues who will lift a LASIK flap 20 years down the road, and they seem to not have any issues with epithelial ingrowth.
Yeah, I mean, I think the studies have shown that your relative risk of developing epi ingrowth goes up significantly 3 years after the primary procedure. That's what the literature shows. And when we did our own review, ours was consistent with that. That being said, I've had patients that have been, farther out than 3 years, maybe 4 or maybe 5 years post LASIK, where I've done retreatments where I've lifted the flap. I think particularly if they're hyperopic LASIK patients, older patients, and over 3 years out, I think in that scenario, it's probably better to leave the flap alone and do a surface ablation or do intraocular surgery.
Yeah, perfect. I totally agree. My threshold is about 3 years as well. And after that, I'll do PRK. And then maybe last question before we move on. Greg, how do you feel in general about doing a hyperopic ablation on top of a former hyperopic ablation? Because personally, that's something I'll usually shy away from. And like Robert suggested, this is personally a patient I would do refractive lens exchange on.
Yeah, we're all in agreement. I don't prefer to stack hyperopic ablations on top of each other, especially when they're spaced by many years. It's likely a different optical zone. It's different laser technology that was used then versus now, and so the predictability of the outcome, I think, is going to be less than ideal. And I still think it's not going to be the best long-term solution for this patient. So this is someone I would almost certainly advise a refractive lens exchange approach. And the lens that we really like for these post-refractive corneas is often an LAL lens.
So that's exactly what we did. We did refractive lens exchange. This patient was thrilled. 2015 with the light adjustable lens in the first eye, J1 plus, replicated that monovision he loved so much previously. And then after the second lock-in, something happened where all of a sudden now he ends up with 2 diopters of astigmatism. And he just feels like something went wrong during that second lock-in, and there's something wrong with this lens that's in his eye now. And he just says, Doc, can you just take me back to how I was before the second lock-in? Dr. Yu, how would you handle sort of this situation here? How would you talk to the patient?
I'm not familiar, but we don't use the light adjustable lens. So I'm not familiar with what are the potential complications of the lock-in, this UV sort of set, and whether or not you can see refractive changes because of something that changes in the structure of the lens or something that's happening to the cornea. But those would be things that I'd be thinking about, really trying to figure out where is this 2 diopters of cell coming from. So I'd start from the beginning, looking at topography, getting a UBM, and really trying to sort that out first before venturing to guess what the treatment would be.
That's exactly what we did, Sonia. Everything was normal, believe it or not. And so, and this is not really something you see that often with the light adjustable lens. There have been some reports of small, mild post lock-in shifts that take place, but certainly 2 diopters of astigmatism, very unheard of. And so I had never seen really anything like this before. I reached out to RX Sight to get their feedback, had them analyze the light treatments, the refractions, and really the only advice from them was, if you're going to exchange it for another LAL, maybe just space out the treatments a little bit further, which to me didn't really make too much sense because the patient was thrilled after all the treatments in the initial lock-in. So clearly just something happened in the second lock-in that just usually doesn't happen. And so ultimately the patient wanted an exchange. And so I knew I was going to have to take this locked-in light adjustable lens out. But then the question was, do I put in another light adjustable lens and start over? Or, knowing now what refractive target the patient likes, do I just put in a high quality standard monofocal lens and aim for that? Greg, do you have any thoughts about that?
Yeah, if I was the patient, I'd probably be a little concerned that the same thing, something weird about my eye might cause the same result to happen again. So I think putting in a lens with the target that is desired is an option. And the other lens that comes to mind that I think is nice in conjunction, and especially in the near eye, is the Apthera lens. That's available now, so that would have been another one that comes to mind as an option here.
Yeah. All things I considered, but ultimately at the end of the day, this was just a patient with a very, very particular personality. And he just had it in his mind that there was something wrong with this light adjustable lens after the second lock-in, but everything was perfect before that. And so he said, Doc, can you just give me another light adjustable lens and can we start over? And so that's what we did. So I proceeded with a light adjustable lens exchange. We don't have time. I won't show the video here tonight, but LAL that's not locked in acts like any other silicon 3-piece IOL, really any other hydrophobic acrylic IOL or hydrophilic or hydrophobic acrylic you're going to explant. It's pretty easy to do. Standard, many techniques for taking out an IOL. But once the LAL is locked in, it's incredibly brittle. And so even in the eye, using large tooth forceps, anything, the IOL tends to break up into pieces. And so what I used was the Snyder Osher IOL cutter. And I'd seen previous attempts from other surgeons at cutting through a locked in LAL and just seeing it break into pieces. But this cutter just cut through it like butter. And it was really one of the easier IOL exchanges I've ever had to do. So I'll just put that there for anyone watching or who watches this afterwards. That's really a terrific instrument. And so, Greg, I'll turn it back to you. Now that this has been done, do you change really the goal for the light treatments now, knowing what the patient likes? Do you follow sort of the same refractive pattern you had the first time? Do you space the treatments out like our Excite recommended?
I might alter my primary lens power to get closer to what the result was so that I had to do less adjustment. But I don't know if spacing the light treatments would make a difference or not.
Yeah, and I was go ahead, Robert.
Sorry. Yeah, the other thing to think about, it wasn't the case here, but if you see somebody who suddenly develops two diopters of astigmatism late in the process, think about basal membrane dystrophy with a map region that developed as a result of a contact lens application, which can if you have epithelial slippage, you could develop something like that. Again, that wasn't the case here, but just something for the audience to think about.
That's a great point, Robert. And there actually have been a couple case discussions on the Refractive Surgery Alliance of people having these sort of odd refractive shifts that people have thought have been maybe attributed to either the gel or solution being used to couple the lens on the eye or something just with that. And so that's certainly something worth thinking about. So, Greg, I was in the same boat. I looked at the refraction. It was in between. What he liked was in between the initial IOL power and one step away. And so ultimately, I just put in the same IOL power as the first time around. We spaced out the light treatments by a little bit. There was no issues the second time around, and the patient was happy. So kind of an interesting case. Again, one of those things where most of the time with refractive surgery, things go exactly according to plan. But every now and then you have to guide the patient on a little bit longer of a journey than you maybe initially anticipated. So case 3, we have a 45-year-old female, very high myope. She's seeking vision correction. She has a history of long-term steroid use for systemic disease. She doesn't really have visually significant cataracts. She has this questionable posterior polar opacity looking sort of lesion in her left lens, and then some lattice degeneration in the periphery. And then she has small anterior segments. She's not really a good candidate for ICLs. And so, Dr. Yu, let me ask you, what are you thinking about when you see a patient like this? I've already said ICL is not a candidate, but would you do laser vision correction here? Would you do refractive lens exchange?
I think she's a little bit high for LASIK for me. If she has this history of long-term steroid use, she already has a posterior polar opacity, maybe this is a PSC cataract. Maybe this is something that she's had congenitally. She refracts to 20/20 still?
Yeah. Mm-hmm.
Again, you'd want to sort of get a sense for how much this opacity is bothering her, if at all. Is she having any glare symptoms, difficulty, with night driving? With congenital polar opacities, they tend to be asymptomatic until people start to get to this age range, because they start to become presbyopic. The posterior polar opacity is near the nodal point of the eye, and this is typically the age at which patients with congenital polar opacity start to become symptomatic. So I try to get sort of a sense for what the quality of vision is and if she's having symptoms, because that might push you towards doing a lens surgery.
I really love that you said that, because, you know, as refractive surgeons, sometimes we're always trying to find a solution. A lot of the times these patients coming to us, either their optometrist or primary eye care provider has told them, you're not a good candidate. Go see, you know, Dr. Parkhurst or Dr. Yu or Dr. Maloney, who specialize in refractive surgery. And so we're always kind of come up with solutions. And so this was a patient I kind of really dug deep to find out how bothered was she by her vision. And the answer was not that much, because I think if she was super bothered, then maybe the risk to benefit ratio for these various procedures may lean towards doing some sort of intervention. But, you know, ultimately, I looked at her biometry. She's got a 28 millimeter axial length, no PVDs in each eye. She's got lattice degeneration. I'll skip ahead to the next slide here, but this is a free online calculator that you can use, supported by peer-reviewed literature, to try and predict someone's risk of retinal detachment. And when you plug in everything, she's 45, she's about a -12 spherical equivalent, has lattice degeneration, no PVDs. She's a female with a 27 to 28 millimeter axial length. You know, her yearly baseline risk of retinal detachment, surprisingly, is a lot lower than I thought. It's not very high. But if you're doing cataract surgery or refractive lens exchange, that goes up to about 3%. And we know from Bob Osher and Avi Vasavada, who've shown us in the 90s and the early 2000s, if you have a true posterior polar cataract or opacity, the risk of breaking the bag, even if everything is done perfectly, is about 26%. And so if there is vitreous loss, you're seeing the risk of retinal detachment in this patient going up to almost 4, almost 5%. And the question is that risk worth it? And ultimately, because the patient really just wasn't too bothered by the vision, we discussed waiting until maybe true PVDs developed, or if the lens changes continue to take place on the steroids, then maybe if things truly were becoming visually significant, maybe the benefits would be worth the risks. But in this situation, ultimately, I advised to this patient no surgery and just waiting. And so let me ask you, I'll turn to you, Greg. When you're having these nuanced discussions, how do you either let a patient down and tell them, hey, sorry, you're not a candidate? You know, maybe they'll go to a different surgeon in town and have a procedure because that surgeon wants to just have their business and say yes. How do you go about saying no to a patient?
Well, I like to explain as much of it as I can so that the patient understands the reason for the recommendation around waiting. And in unusual cases like this, where there's not really a clear answer is, you know, what should we do right now? You know, I think the answer, let's wait and monitor, is often a really good default answer. And I think that allows for additional time for, you know, additional rapport and trust to be built between, you know, the doctor and the patient. And when you get in, as we were discussing earlier, when you get into these kind of like unexpected outcomes or unusual situations, you really want to be able to lean on that relationship that you've built with your patient via trust over time. And I think there's no substitute for sometimes having additional conversations separated by time, months apart, maybe multiple times, to have that conversation develop into, you know, are you ready to move forward with this? And then oftentimes, at some point along the way, something with the equation changes. Maybe the patient becomes more symptomatic.Maybe they have their PVD. You know, there's been cases that you presented like this one, where sometimes we've especially if they're presbyopic and we're a little bit concerned about doing intraocular surgery relative to retinal detachment risk. We've even done just a debulking of myopia by doing a laser vision correction with that, not having the goal to produce emetropia, but just reduce from, let's say, -12 to -4, something like that, which is a much more reasonable refraction to live with and function with. So, you know, I think that some of those different, you know, final outcomes with a surgical intervention can best be determined over time after multiple visits with the patient.
That's terrific. Robert, any thoughts on that?
I just get back to what Greg said earlier, which is it's important to be able to say no. I remember a patient came in once, this is a number of years ago, who wanted LASIK. And I just felt like her expectations were unrealistic. But she said, I'm trying to decide between you and Dr. X, who's another doctor in the LA area. And I was feeling a little competitive, like, wow, I really think you should come to see me. But I didn't say that. I just said, I think you should go to Dr. X, which I had to swallow my pride. Because I don't think you're a good candidate. I don't think you'll be happy. So Dr. X did her surgery. And a year later, I got a letter from a lawyer subpoenaing my records because she was suing Dr. X because she was unhappy with the result. It just gets back to what Greg said at the beginning. It's really important to be able to say no if vision correction is not the best thing for him. In a patient like this, contact lenses are probably the best thing for him.
Wonderful. We have one last case here that I'll bring up. We have a 60-year-old male. He's essentially hemetropic, really doesn't have much refractive error at all. He's one of those individuals that has led a very healthy lifestyle. Slit lamp exam, you would expect to see maybe some trace to 1+ NS, but really his lenses are quite clear. And he's just using reading glasses and, even cycloplegic refraction about the same. He's a good candidate for any laser vision correction procedure. All imaging is normal. And so, Sonia, I'll turn to you. What would you do here? 60-year-old male. Would you do LASIK for monovision? Would you do refractive lens exchange? Or like we just discussed, would you do nothing?
Yeah, this is a tricky case. You certainly could try monovision. I usually would offer the patient a trial of contact lenses to see if monovision works for the patient. And if they could get adjusted to monovision and contact lenses, I still think at 60, you're not too old for LASIK. And I certainly have patients that are 60 that I've done LASIK for monovision in terms of refractive lens exchange, these are tricky cases because the uncorrected vision is very good. And again, if you look at the literature for refractive lens exchange, we're about 85% to maybe 90% within plus or minus a half of target. That means 10 to 15% of the time, we're going to be outside of that plus or minus a half. And for this patient, if you're in that 10 to 15%, the patient will not be happy. So, I think it's very important that they understand that they could be sacrificing some of their uncorrected vision if they decide to go with a refractive lens exchange. I think you're pretty much going to nail the better reading vision at J10 pre-op. And this patient, if they decide to go with a refractive lens exchange, should be counseled that they may need additional procedures to fine-tune the final outcome.
That was beautiful, Sonia. That was really terrific. I agree with everything you said. And it's interesting when we're not really taught refractive surgery in residency. So as a resident, my impression of LASIK was, well, that's, I had LASIK on my own eyes halfway through medical school, but I said, that's probably a procedure for people in their 20s and 30s. And it was really only in doing a dedicated refractive surgery fellowship that I began to really have conversations with patients in their late 40s, early 50s who truly were seeking vision correction in the form of LASIK or PRK or SMILE. And, I would ask some of these patients, what was it that motivated you to have this done now? And for a lot of people, they're just finally at a point in life. Maybe the kids are off to college, they've paid the mortgage on their house. They're finally at a point in life where they can do something for themselves. And even though they're going to develop cataracts in the future, they can still really benefit if they're a good candidate from the power of vision correction. And so I agree completely. I've done LASIK or SMILE or PRK on patients in their 60s. And, if they're a good candidate, they're still going to reap the benefits of that. And I agree with someone who just has really good uncorrected vision. I'm very hesitant about doing refractive lens exchange with a multifocal or even an extended range of lens where they're still going to suffer a little bit of reduction in contrast sensitivity, or maybe they just will start having dysphotopsias they don't naturally have yet in life. And so we did exactly what you said for this patient, did a contact lens trial. Patient was thrilled, loved it, did LASIK just in the one eye, not too high of a hyperopic ablation. And the patient was very happy, and understanding that in the future, when it comes to doing cataract surgery, options might be limited in that eye in terms of using a multifocal lens or other advanced technology. And so what I wanted to do really by talking about all of these cases is bring up conversations that we usually don't have in training. All of these patients were patients who came in for an elective procedure. They didn't have to have it done. This is not someone who has a retinal detachment and we have to do surgery, someone with a corneal ulcer and we have to intervene. And so there's a lot of gray when it comes to refractive surgery, and every surgeon has their own personal thresholds, their own limitations, maybe the types of technologies they have in the office they can offer patients. So I wanted to just close out this brilliant season here with all of these amazing discussions that took place and really focus on something that's not really concrete and is more abstract. And hopefully everyone listening in either live or in the future got something out of this. I know I certainly benefited from a lot of these amazing conversations here tonight from our expert celebrity panelists. So I'll just close with that. Thank you, everyone.
Thank you.
Arjan, that was an absolutely stellar final episode. I think, honestly speaking, it wraps up what Rising Stars in Ophthalmology means to do for all of you guys. And I think it's really, really important that Bob, Sonia, Greg, all the panelists who've been part of Rising Stars have really commended you guys to come up and stand on the podium and give these talks with such confidence at such a young age. It honestly baffles all of us at many, many levels. But honestly, I just want to wrap up this whole episode specifically. You've navigated through so many confusing points which all of us as refractive surgeons face, navigating through the flaps or the smile. Then you spoke about ICL, how we navigate between ICL and refractive lens exchange, how we don't take up those cases. Most importantly, I think the panelists, chipped in on the points of honesty and truth to the patient, and that's exceptionally important. A lot of us shy away from it because of fear of rejection or fear of losing out. There's so many aspects to it, but I think it's such an important aspect that we keep talking about it and keep bringing it up at different points and levels. At some point, the consciousness kind of takes over, and we do the right thing for the patient. You did speak about LAL as well and how important that aspect of IOL exchange is, and I think that's a critical aspect I don't know about personally, so I'm sure that a lot of people like me out there who don't have experience with LAL learn from these kind of conversations. And Bob spoke a lot about the hospitality segment rather than a hospital segment, which we are in today. Bringing that experience or patient experience to the patients. That's a critical aspect. So these things kind of sum up the whole Rising Stars in Ophthalmology, what it was. We were looking at it from a clinical standpoint. Now we're moving to this whole hospitality and patient experience standpoint. And, bringing in new blood really helps refresh our system and, helps us do better or what we were doing before. So that's a little bit of a wrap for the Rising Stars Season 3 final episode. Thank you so much, Bob, Sonia, Greg, for being here for the final episode. And audience, if you're watching, please look out for Instagram and Facebook feeds on all our educational tips. We are going to have a lot more from Season 3.
Thank you, everyone.
Thank
Bill?
you. Thank you so much. That was great.
Okay, these
Did
are
we stay on time?
final,
I wasn't sure. I didn't see a timer.
Okay.
You stayed
Have we ended
absolutely
record?
So these are the
We
final
finished the broadcast.
sponsors: Allergan, Alcon, Vices, Dompe, Avellino, Young MD Connect, Sun Ophthalmic, and Tarsus. Thank you very much for being part of this Season 3.
Okay. And broadcast.
Thank
you, guys.
Narayan?
Yes.
Good job, Arjan. That was great.
Thanks, guys. And thank you for spending an hour, from around the world to do this tonight. It means a lot, really.
Of course. I think it was a great episode.
So great.
Very constructed. Thank you so much.
That's fantastic.
And all of you, I will see you in San Diego.
Awesome.
Look forward
Thank you so
to
much.
seeing all you guys. Hey guys,
Sonia,
that was great.
you're going to be
You
in
guys-
my time zone. So give me a shout out when you're here. Which city are you going to? I didn't connect with that.
Jamnagar. Jamnagar.
Okay. All right. Okay. That's far.
I'll
Cool.
give you the details. It's pretty
Okay.
interesting.
Can we go off?
Awesome.
Right.
Bye,
So,
everyone.
thank you so
Thank
much.
Bye,
you.
everyone.
Bye-bye.
Thank you.
Good night.
Take
Have a
care.
good evening. See ya.
See you.
Good
Night.
Bye-bye.
Bye.